past 25 years. Although a dedicated clinician, her passion about professional advancement and developing well-trained graduate physiotherapists in Eastern India led her into academics, which saw her as Director Education of Naponi Institute of Health Studies, the first private physiotherapy college in Kolkata in 2004. As NIHS gradually became a center of excellence, Dr. Agarwal was entrusted with the responsibility of Nopani Institute of Management Studies. She is currently the secretary of the Nopani Foundation Trust. With a master's from University of Wales, College of Medicine, Cardiff, UK, and a PhD from Curtin University, Western Australia, Dr. Agarwal combines this extensive academic exposure with a vast experience in both academics and clinics. It's an honor to have you, ma'am. We give you a warm welcome.
Thank you so much. Thank you very much.
I would also like to introduce our panelist, Dr. Nilima Bedekar. Ma'am has done her BSc PT from GMC Nagpur, MSc from University of East London, UK, and hold a PhD from Pune University. Currently, ma'am is professor and HOD Musculoskeletal Department at Sancheti College of Physiotherapy, Pune. She is also a PG guide. She was a former member of Academic Council, Research Board, and Chairman UG BOS at NUHS Nasik. She has over 30 publications in national and international journals and has presented several presentations in national and international conferences, including WCPT, Yokohama, Japan. We welcome you, ma'am.
Yeah.
Without further ado, I would like to hand over the mic to Dr. Shabnam Agarwal for today's engrossing topic, sarcopenia. Over to you, ma'am.
Thanks, Dr. Farheen. And as I have said before, it's a pleasure to be on the same platform as Dr. Nilima. I'm honored to be here. And thank you for inviting me to deliver this lecture. And as Farheen said, without further ado, I'll start. Ma'am, should I?
Yes, please. Yes, please go ahead. We are waiting.
Thank you so much. Thank you.
Yes. Presentation, as usual, it's so great. Yes.
Please yes, start. Absolutely, ma'am. Thank you.
Yeah.
My screen is visible?
Yes, ma'am, it is.
Okay, thank you. Right, so sarcopenia, a reality of aging. The reason why I've chosen this topic is something because we've been working extensively on it. We realize that it's an underexplored condition in India, and we as physiotherapists have a great role to play in it. And so this is the combination of things which led us to work more on sarcopenia, and I'd like to share that with the entire physio fraternity. I've been introduced well enough. All I can say is that I am grateful to God for giving me the opportunity to be working in such excellent organizations. And today, again, I thank Sancheti College and hospital for inviting me for this TV show. It's like, as I say, it's good to be on TV. Right. So what I shall talk about is who exactly are older people or the people who have sarcopenia. And then we want to know how many of them do we have in India, because that's where our focus is. That's where what they say is our karma bhumi. Sarcopenia, what is it? How does it affect the elderly is something that we would like to talk about. And what really happens with older people? How active are they? What is their fitness levels? What is their functional capacity? And the other is how active should they be? What are we recommending, or what is the current recommendations regarding their physical fitness and their activity levels? And finally, coming from us professionals, the physiotherapists, the exercise prescription for them, which what I would like is that each one of you who's listening to this should go home and immediately be able to practice this rather than study further. It's very simple. It's some of the basics that we normally do, but given in a condition, there are other things that you need to be thinking about, because when we talk about the elderly, remember we are talking about a fair number of comorbidities as well. So whatever we do with them, we need to exercise caution there. So what do we mean by older people? So there's this little cartoon that I got, and I thought it was very appropriate because it says old is when you're napping, but everyone's worried that you're dead. And there are a few times, and we've entered a patient's room and the patient's sleeping so soundly, an elderly patient, we've actually kept our finger under the nose to feel the breath, of air. So it is valid, it's valid. And but again, age is not an accurate predictor of physical condition or behavior. Age is only important if you're cheese. So we are not cheese. We are human beings, and we can modulate our physical condition based on our physical activity, based on our mental activity. So let's go on and get on and see how that works for us. Uh, so what basically really works is that this aging process seems to be, or the physical condition that we are in, it seems to be driven by lifestyle choices, which is the amount of exercise you do, the amount, what nutrition you have, what is your stress management, what your genes are, and the environment that you live in. Now, in the first picture, you can see this old man, kind of smoking through a hookah. And so one thinks he's probably in a leisure, but you can make out that there are fields behind him, and he's probably done some work in the fields and then come to smoke his hookahs, which is fine. At least he's having leisure time. He looks like he's enjoying himself. And the other guy, you can make out the white beard, but he's still kind of using this piece of equipment to possibly plow or something like that in the field. So this is what it is. I would guess rural life means better exercise, more activity, better nutrition, better stress management. But then all of us can't go back to the villages. So we need to make the best of the condition or the environment that we live in. And so we need to modulate physical activity based on the environment that the individual is in. So what is it about age? We all age. We are all aging, but we all age differently. And that's the reason why when you are dealing with people with sarcopenia, you need to remember that you're not dealing with a homogeneous group. So there could be 10 varieties of people who are above 50 years of age. One person who's led a sedentary lifestyle and could be with a lot of comorbidities and physical issues, whereas another person could be playing 2-3 hours of lawn tennis every day. So it's not a homogeneous group. And when we call someone older adult, that is a person who's aged over 50, and that's, I guess, I come in this category now. And there's significant variations in health and functional capacity. It all is dependent upon, as I keep reiterating, what you do in your life. And the most important thing is self-identification. There the matter is half solved. And what does this mean? This means that, when a person comes to you and says, I did this, and that's the reason why I've got this. The person doesn't turn around and say, well, I'm this old, and therefore I guess this is going to happen to me. So if a person is 60 plus and the person has been playing tennis, they've gone and injured a muscle, the idea should be that, okay, look, I played tennis and therefore I've got this. But if they turn around and said that, I guess this is age and this is bound to be, and I accept it, and I guess I need to stop playing tennis, that's what everyone in my family is saying, then that is not good for the individual. That's detrimental. So self-identification is important here. Now, in India, what's the aging scenario? What we did have earlier was this kind of a joint family setup, which you can see on the left, and you had everyone taking care of everybody else. And we didn't need external social security like they have in some of the other countries, because our families were enough. Whereas we are gradually moving into an urban household where you have a one or a two children household, and you can look, maybe these guys on the left look a bit somber and a bit serious, and this little trio on the right look happy. But think about the same trio around maybe 40 years later when this man is old and the woman is old. And there's just one child who has the burden of looking after the older people. Now, the reason why I use the word burden is not because older people are burdens. No, no, no. The reason I'm saying is that if these guys continue to be active and fit, then our burden, which is like people who are above 50 and then move on to 60 and 70 and 80, we are hopefully less of a burden on our children or youngsters in the family, rather than just because we are older, we need to be looked after. So we also remember that when you are alone, when you're an individual family, there is more requirement of providing, health care issues, and economic issues become a bit stretched. So this is probably moving from this to this, and that's not a very good movement, really. So how many of them are there now? How many older people? That means how many people are there above 50 or 60 or whatever? Is that we've got information where it predicted that uh, from 8.3% of India's population in 2011, there would be 12.4% in 2026, right? And so there was another one from the aging division from the Ministry of Social Justice and Empowerment, which said that the people who would be above the age of 60 would increase to, let's look at the current figures, 143 million, which means basically 14.3 crores out of the 130 crores, which is a huge number, isn't it? This is almost the entire population in some of the other countries. So we are currently a young country. Yeah? India is a young country, and we pride ourselves in saying, oh, we are young, but we are not young forever, are we? We're going to get old. And this you can make out that the number is increasing here. In 2026, you're going to have 17 crore people who are going to be above the age of 60, which is a huge number. And so who has a role to play here? We, the physios, because we are the only profession which deal with all the problems which come with aging. I'm not talking about the deeper or the specific medical problems, but generally all the problems. So now I come to sarcopenia, which is defined by WHO under the International Classification of Diseases. It's got 10th CM or 10 CM as the identification code. And this sarcopenia is a lesser known cousin of osteopenia or osteoporosis. Everybody talks about osteopenia and osteoporosis, but you have to understand that until and unless the muscles are strong, they're not really going to help the bones, are they? So sarcopenia requires, if not the same, but more attention than osteopenia, but it's a relatively newer kid on the block. And so it'll take time for us to put it on the same level and give it the kind of attention that it requires. But I must tell you that government agencies have started looking into it. And as I said, in old age homes, they are identifying this, and it is soon going to become one of the most talked about topics in India, because as I said, the older population is growing and they need us, or they need this to be identified for us to be able to work on them. So what is sarcopenia? It is age-associated decline in muscle mass. That's the first thing. What does it literally mean? Sarco means flesh and penia means deficiency, as we all know. And initially it was described by Rosenberg in 1989. So it's not a very old thing. 1989 was just a few years ago for that matter. And as loss of muscle mass. Currently, it is defined as an association of the loss of skeletal muscle mass and function with advancing age. And it is associated with loss of function. Loss of function leads to falls, hospitalizations, and therefore, after that, there's a gamut of things that occur and events occur, and there's increased mortality. So what are the changes that we witness in the musculoskeletal system? We all know that. This is a quick recap. So the musculoskeletal system is composed of bones, tendons, and ligaments, right? And so we're actually looking at a gradual loss of bone mass. And you know that it starts from the age of 30, more in women than in men. And Then there's, when you look at the cartilage, then there's decreased water content. When we look at the intervertebral disc, there is reduced water content, which reduces to degeneration of the intervertebral disc. And this degeneration of the intervertebral disc causes a reduction in height. And then you see older people becoming shorter than what they actually were initially. And also you find that you become stiffer. There's that water content in the tendons and ligaments reduce, and you tend to become more stiff as you grow older. You're not so agile, you're not so flexible. And in a sarcopenia, the muscle looks like this. So this is an average healthy muscle. The center white piece is the bone. The little dot in the white is the bone marrow. Around is the nice red muscle. And then on the outer layer is the fat. Whereas a sarcopenic muscle looks like this. The muscle has shrunk. The fat tissue has grown. And that's why you will find that older people have less muscles, and because they have less muscles, their ability to do work reduces, their ability to do recover reduces, and then the chain reaction happens. If we have to look at a MRI image cross section of the muscle, then that it looks like this. This is the original, this is the sarcopenic muscle. You can make out the increase in the fat content and the reduction in the muscle. So it's a vicious cycle. Sarcopenia, as we know, is a loss of muscle mass initially, and later on it is associated with the loss of muscle strength. This too starts from the age of 30. Now, again, it is dependent upon your activity and how much you use and how much you don't use. Then this is gradually, people get, they don't have strength and they feel a bit tired working or using it. So they end up with reduced mobility. And this reduced mobility leads to frailty, osteoporosis, and then there's an increased risk of falling. And then they can't work, even activities of daily living become compromised. Then remember, this affects all the muscles. So it's not just the skeletal muscles, even the respiratory muscles. And we saw the role of respiratory muscles in this recent COVID, where we found that physios have a great role to play. And the reason is because we kept activating the respiratory muscles. And so older people, you will find very easily complain of, shortness of breath, or they have constipation very often. So these are the reasons, sarcopenia. And because of reduced mobility and reduced muscle mass, type 2 diabetes occurs, and there is a very slow weight gain, which is terrible, but then that happens despite the best of intentions. Weight gain does happen. And there's loss of physical function and independence. So you don't want this to, number one, happen to, let's say, your patient, or let's say your parents, or let's say to yourself. So you need to work at it from whenever you can. That if today you are 25, you need to start working at it. If you're 14, you need to start working at it. And even if you're 60, you need to start working at it. Because it's like, what they say in Hindi, jab jago tab savera. So if you start working from now, it's never too late. So the other thing is that it's an inactivity related disease, isn't it? So, we age and there is a loss of muscle mass. But what happens when there is a disease and that causes disuse? 1 week of bed rest reduces our strength by up to 20% and the bone mineral content by 1%. So we have, forget about bed rest or disease processes. Most of the older people nowadays spend 80 to 90% of their time either in sitting or in lying down, because they are watching TV or they are on their phones, or basically they are sitting. So this is going to lead to inactivity related sarcopenia rather than a disease induced sarcopenia. And why do we need to act? We need to act quickly, because even a small reduction in the sarcopenic population would save crores of rupees. Sarcopenia contributes to numerous other health problems, and it also contributes to osteoporosis. And as I said, it's a poor cousin to osteoporosis. It doesn't get the same amount of amount of mileage as osteoporosis. And one of the major reasons could be that of the drug industry, the amount it can contribute to bone growth. A lot of muscle growth cannot happen because of supplements, can it? Muscles have to be worked on. Mehnat chahiye uske liye, and people are not ready to do that. So, although it is inevitable, some amount of muscle loss will be there, but there are therapies and intervention that can halt or reverse these processes. So that is a possibility, and that's where our role comes in. And this is important for the family, the society, as well as the country and the universe as a whole. Because if you have a lot of sick people, I'm sure you've recently experienced it, one sick patient in the family can kind of disrupt the entire family's activities. You don't want anyone to be sick. You don't want anyone to have a problem just because they did not move. So movement is the mantra, and who better knows that than us, the physios? So classification of sarcopenia, if you find this slide a bit busy, just listen to me. So there is this European working group on sarcopenia in older people, which is called EWGSOP. And they kind of classified sarcopenia. They said that the person has low muscle mass, then they are like primary sarcopenics, okay? Then if they have low muscle mass, plus as well as low muscle strength, then they are sarcopenics. Now, if they have low muscle mass plus low muscle strength plus functional limitations, then they are severely sarcopenic. So because this was a European working group, and a lot of times the whatever is done on a European population does not translate to an Asian population, we also have an Asian working group of sarcopenia. Okay, and they classified sarcopenia along the same lines. Now, we've got certain issues with chosen measures, because with sarcopenia, what happens is that, just a second, yeah, the issues that with the chosen measures is that, let's say, if I, for muscle mass, chose the DEXA method, and you, for muscle mass, measured the muscle mass with the BIA, which is like the body impedance measure analysis. Okay, and then someone else chose a calf circumference. So although there are predetermined cutoff points and everything is there in place, you will find in the same population that if you use one measure, you might find that a certain set of people are sarcopenic, whereas if you chose another measure, then you would find that another set of people are sarcopenics. So this is where our research is getting a bit stuck about sarcopenics, because they are still measure dependent, and because they are measure dependent, the world has not yet come to a fixed criteria that only with this method, if you choose, then are you going to be able to assert that this patient is sarcopenic or not sarcopenic? So this is where research is getting stuck. And anyone who's doing research on aging or sarcopenia, please, I'd be so happy to discuss this with you, because this, and I know maybe we can do multi-center trials, because we've done it in Eastern India and Bangladesh, but we would like to do this in the rest of the country as well. So let's say when we talk about sarcopenia, we want to know that how many sarcopenics do we have in India? So this is all the research that we've got from India. We've got from people who are in old age homes, in the society, or we've also got people with a disease like diabetes and without diabetes. So the first one was in an old age home. The second one was in a diabetic center, and the third one was in a tertiary care center, right? Overall, they found that the prevalence of people with sarcopenia is around 15 to 17%. So this is what you're looking at. You're looking at 17.5% here in the first research, 15.8% in the second research, and 15.3% in the third research, right? And when we measured, we are still in the process of publication. We collected data from old age homes. We found that people who are pre-sarcopenic, that means the people who had low muscle mass, were 14.52%. The people who could be classified as sarcopenic were 20.67, and severely sarcopenics were 8.19%. So this is what we've got data so far. It's kind of matches the data from other Asian countries as well. And I mean, once it gets published, I'd be happy to share the findings with everybody. Now, the other is this aspect was like looking at muscle mass, muscle strength, and functional scores, but or let's say to see how much the person can function in ADL, were methods to find out or determine the prevalence of sarcopenia in a society. Now, as a clinician, if there are clinicians listening to this, you just want to find out how much the person can do and cannot do because of sarcopenia. So these are all your scores. The SARCOL, which is the Sarcopenia and Quality of Life score, which we have translated into Bangla. And this is looking at 55 items into 22 questions. It's pretty long. Then we've got some other methods, and you can use any one of these scores to determine how much your patients or whoever is around you, you're concerned about, how much they are being affected in their day-to-day function because of sarcopenia. So what is the best management? What is the best evidence, right? So we're looking at exercise, which is aerobics plus resistance, and we're looking at diet, which is protein. And what they say is that, of course, exercise in variety of forms. I'm going to get into it. When we look at protein diet, I think a lot of India is pretty good about it because we have more than cheese. We have dahi, yogurt, curd, जिसको हम कहते हैं, and curd items are excellent sources of protein and also provide probiotics for the gut. Remember, as you grow older, the gut also has various issues. So giving or having dahi, curd, chas, lassi are excellent. And so when they say that, or chena for that matter, so when they say that have a lot of milk products, please advise your patients to have a lot of these. If they can tolerate milk, then well and fine. If they can't tolerate milk, then they can have yogurt, dahi, and chena and things like that. Now let's look at how does physical activity benefit for the older people, and well, we know that it makes them independent, and it's called successful aging. So you're looking at social networks and independent living, quality of sleep, and basically they are able to maintain their activities of daily living without being dependent on others. So this is how physical activity would help them. The other aspect is management of disease. So if they are physically active, then all these diseases like heart and diabetes and the bones and cancer and falls, all of them get reduced, right? So it's not, there might be a lot of people who say, abhi tak to kuch nahi kiya, so abhi karen kya? Yes, karo. As I said, jab jago tab savera. Start it now, start it today, start it tomorrow, but start the movement. And that's what's most important for most people. And finally, the psychological benefits. You do realize as clinicians and even as academicians that a lot of older people have psychological issues. They're depressed, they're lonely. And so physical activity reduces stress and anxiety. It reduces depression. It causes an overall psychological well-being, very important, and also improves cognitive function because you don't want an older person who's sitting there and not being able to grasp what is happening around them. And also because they're independent and because they're not depressed and they are good, so there is they are good in their self-esteem and self-worth. They don't just keep saying, oh well, we're going to die, we're going to be old. They're like full of life, where they're like, oh yeah, let's go and have an ice cream, and like these women, let's dance and kick it higher. So also because they are well and they can move around, then obviously they can move around, and that reduces their isolation and loneliness. They don't have to be children dependent all the time. They can move around with their peers and socialize and be happy. Now that was the benefit, but that's not the story. That's not the complete story, because now we need to know how active are older people. I mean, do we know how active they are? Well, yes, because unfortunately, physical activity is disappearing from everyday life. Why? Because everything is labor saving. TV भी उठ के नहीं on करना होता है. There's a remote in your hand. Then the transport patterns and concerns over safety in public spaces. Like I can't even think of sending my parents or anybody like that in public transport anymore, because if they are elderly, the kind of footpaths we have, at least we have them like that in Kolkata. I mean, I can't even think of an older person walking on those footpaths. They're so uneven. So, but I know that Pune is better. So the uh, you need to go by car. You can't go by any, or a taxi. You can't go by any other mode of transport. You definitely don't want them to move around on the footpaths of Kolkata. Sports as an entertainment is on TV rather than playing it themselves. And the impact of information technology, I'm sorry, pardon my language, the damn phone. I mean, on one hand, the phone is excellent because you have a FaceTime or you have a video call, but on the other hand, the amount of time older people spend on their phones, they definitely don't like moving around at all. And so this is the kind of competitions one has now, which is the final round of the biggest snoozer in the room. So you overall, for all of us, lifestyles are less physically demanding, and that's the bane of the entire matter. That's where we are all going wrong. So we've got, there was this research which was conducted in England for men above 50, and you can make out the key, which is for people who walked over 2 miles and for people who walked briskly over 2 miles, normal walking over 2 miles, and all walks, all any kind of walk, whether even to the toilet, more than 1 mile. I mean, no, the toilet is not 1 mile away. It's just, the sum total of the entire day. And you find that as people become older, by the time they become 65 to 69 years of age, they stop brisk walking. Okay. And by the time they become 75 to 79, then they definitely are walking much, much less. Look at the amount they're walking. They're like this walking 40%, like 40% of people are walking 5 times a week, and that's it. That means 60% people are not walking. And this is England, where the footpaths are good. I can't complain. The footpaths are good. They are sloped at the end. There are access for the disabled, yet. And oh, the women are even worse. I mean, there's just these many women who are participating in walks like this, which was there. Now, obviously, this research is a bit old. It's 1999, but I didn't find anything more relevant than this one, and it kind of broke my heart when I saw this. Now, the next slide is even worse because it tells you about the ethnic groups are Indians being quite a bit of a prominent ethnic group in England. And when we looked at Indian men, then if they looked at them participating in 30 minutes of activity 5 times a week, and we have 22% doing that of the men and only 2% of the women. We are even worse than the Pakistani women. So, and slightly better than Bangladeshis. So I really do not know where we stand. Very sad. So physical activity data from India, there was this research by ICMR and India B, and population age was above 20 years. So don't think that this is just a characteristic of people who are older. Look at the younger lot. The population was huge. The sample population was 14,000 plus, which is a huge group. And you had Tamil Nadu, Maharashtra, Jharkhand, and Chandigarh, no West Bengal. And the outcome measure was Global Physical Activity Questionnaire. And the results were that only 14% were highly active, 40% were active, and 54% were inactive. The story doesn't change, does it? And yeah, sorry, the females were more inactive than males. I didn't like that bit, so I went through it a bit faster. Now, what is it? Why are we like that? So let's talk about, we're going back to older adults and we're looking at why do they not move? Why are they inactive? Why don't they do what they're being asked to do? Because there are barriers and their beliefs, their attitudes, and whatever, the motivation levels. Let's have a look. Barriers to activity, that's intrinsic, andar ki baat. And that's like my belief, isse kya hoga? Nothing will happen. मुझे हिल के करना भी क्या है? I mean, I was having this conversation with my patient yesterday, and I said, if you move around and if you do activities, it's good for you. And she says, I went from the hall to the from a bedroom to the hall and back a couple of times. So I said, well, walk further, go to the kitchen, cook for the family. No, I don't have to cook. There's a cook. I said, no, the family would like you to cook. They would like, I'm sure there's some special dishes. No, I haven't been cooking for the last so many years, so I have kind of forgotten how to cook. See, there's no motive, there's no motivation also. So, so this is where activity reduces as you get older. Also in our society, we like to take care of the elderly. So we tell them, once they reach a certain age, our way of paying respect and love to them is, आप काम मत करो, अब आप बैठ जाओ, अब आप आराम करो, अब हम आपके लिए काम करेंगे. Oh, this is the worst that one can do to an older person, because then they've got nothing to look forward to. They are just sitting there, just watching TV or whatever. It's not life really. Like life is like work. Like all of us who actually work realize it's not, it's you. Life is what work is about. If you have good work, that is what is life. There is, I mean, even what do you say? Like the other day, I was reading about Amitabh Bachchan, and he said, "I just hope that I'm working to the last day of my life, because that is what keeps me going." There we go. So also another barrier to activity is previous experiences of the individual. हम थक गए थे पिछली बार हमने किया था, so then I had more pain. I had to visit the doctor. The doctor said, don't do so much of exercise. It's okay, आप आराम से रहो. Then barriers to activity extrinsic, what they get from other people. So as I said, the doctor said, don't do it. The exercise instructor says, धीरे धीरे कीजिए, you don't have to do too much. Then accessible opportunities, like how can they go somewhere and do it until unless there's a park around the corner? How do you walk? What motor transport do you use? The family says, please don't use public transport. Don't go on your own because you may have a fall. Then who's going to come and look after you? So all these things are there, And then we have this entire image of older people saying that, oh, like aram se baithe hain. They're sitting and watching the family go by, the world go by, that's the thing. So the other aspect is that, so we want to know that what makes, what is it that makes them active, and what is it that doesn't make them active, right? So the physiological signs of aging is definitely a big cause for inactivity, because dard hota hai, stiffness hoti hai, so you don't want to be active. You've retired, so therefore there is no impetus to look good, to be active. The children have left home, so there is no one to cook for. You get one illness, and that illness pulls you down so much that you cannot overcome that and become active. You've moved home and you're now staying with your children instead of an entire house. You're living in one room, and life is a bit restrictive. Or, you've lost your spouse, or you lost somebody, you're a bit lonely and alone, you find it very difficult to do anything on yourself. So these are life events, that hold older people back. And what do we want them to be? How active should we want them to be? Recommendation for all adults, and please ask your older people to do this, is just 30 minutes of moderate physical activity on 5 occasions in a week. And that's about it, whether it be walking or cycling or whatever, or maybe 2 days of strength training in a park or in a public group or at the physiotherapy center. Now, people who find themselves tired, because a lot of older people, when you tell them that please walk for 30 minutes, they'll actually faint there. Does it 30 minutes? You think I can walk for 30 minutes at a stretch? So you turn around and say, okay, do it for 15 minutes. 15 minutes in the morning, 15 minutes in the evening, midnight, dawn, whatever time you choose. But please get active. That's what you want to tell them. And so the opportunities that we have for older people, when you are giving them a prescription or when you are counseling them, you need to tell them that they need to continue with their sports participation activity. And playing with grandchildren is a major boost. Most older people love it. Going out to buy vegetables in Bengal, it's a done thing. For the male of the family, take a little nylon bag and to go every morning to the bazaar and get fresh fish and fresh vegetables, which I think is a great thing, because if men continue to do that till they are older, then it's one of the ways of being fit. And keeping a dog or someone and walking them. Even if you're sitting on a chair, certain activities, certain pranayams and yogasanas may be taught to them. Or if they say that we can't go to a park, we can't do anywhere, walk in the corridor, walk in the building corridor, walk in the building complex, but whatever it is, do something so that you are active. Now, can we help to change matters? Yes, we can. Number one, we can give them all the advice that I've just now shared with you, ask them to be active in that sense, that be physically active, right? The dosage I've already given to you. Now we move on to specifics like physios. If a sarcopenic patient came to me, what would I do? Well, if a sarcopenic patient came to me, then I would actually ask them to, I would work on their muscle strength and endurance for all major muscle groups. I would ask them to be flexible. That would help them in their functional activities. And I would ask them to do balance exercises. So this is roughly all the research that we have looked into. This is the basic exercises that we normally tend to use TheraBands, because they give you a little bit of strength training. These are color coded. The amount of resistance they offer, we know that in advance. So we can prescribe the same to our elderly. And we would do elbow flexion, because this would work on the core, on the upper body strength, as well as balance. And same thing with seated row, working on the traps at the back, improving their posture instead of being rounded. Then the bench press and standing. So for the pectoral muscles, so this would help them to reach out. The up, okay, excuse me. Right. So this is what you would be working on, the upper traps, so that it would help you, help in carrying and lifting in day-to-day activities. A chair squat, most of the people tend to have a problem from sit to stand. So this exercise would help them to do a sit to a chair squat. And so, and also if you have a TheraBand, then it kind of works on your stability and balance. It challenges as well as helps. So these are functional movements, and so these are PNF movements, and they help, as you all know. So you can do it with a band, you can do it without a band, but you need to do that. Quadriceps strengthening. Sorry, I was at a hamstring strengthening initially. So hamstring strengthening. The reason why I'm showing bands is because it's simple. They can just tie it anywhere and do it easily, and it helps them. So, and basic activities, no gym required, just a chair and just a band. That's it. So they can do this, of course, with you. And when you give them a home exercise program, it's easy for them to follow this at home. The next aspect, so this was all strength training. There was nothing great about it. It was just that it isolated all the bigger muscles and you ensured that it was worked well. There was a certain amount of basic amount of resistance given so that these people, when they train, they got more of strength training. And because you used bands, resistance bands, there was a neuromuscular component to it. It does challenge the neuromuscular system much more than an ordinary weight. The next we come to is flexibility training. And of course, your main purpose is to increase the range of motion and reduce the stiffness and muscle tension, right? And also to improve posture, because older people have a slightly flexed posture. So flexibility definitely helps you to perform better functionally, and functional goals need to be achieved. Otherwise, older people get very cranky and very what do you say? They get a bit disillusioned with life. So there's a lot of research, but I can share that with you later also, because I think we're running out of time. But I would have liked to first show that you need to do an assessment first, and you just see what are their habits, because you want to customize this. You want to make them understand that, look, this is what you want to do. You want to do gardening, or you have a lot of activities where you're reaching out in front. So fine, I'll work on those muscles first so that you overcome the limitation. You look at their active range of motion as well as the passive range of motion. Active range of motion, you all know, would actually give you a sense of the amount of strength they have. Passive range of motion would give you information about the joint limitation or the joint flexibility. Also the posture, because they're very rounded, they're not really going to have full range of motion, are they? So look, here it is. There's a list that we have. For getting dressed, you need upper and lower body flexibility. To turn to look behind, especially when you're driving a car or when you're crossing the road, you need neck and trunk flexibility. And you look at the list going down. For every work that you have, there is a body part that you can work on to make it more flexible. Okay, and so this is what you have a limitation, kind of make the prescription based on that, so that you first cater to the main problems and then you can cater to the generic problems. And the dose for flexibility is initial warm-up, which is a must. Otherwise, the muscle gets very sore and it's very tight. 3 to 5 stretches. Whole time is 10 to 15 seconds or 5 breaths. And we target the muscles which are prone to tightness or the muscles that you want to work on. You must individualize your exercise prescription. 2 days per week we found is enough. So we stretch, especially the upper cervical extensors get very tight, so you want to stretch them and do an upper cervical flexion. They get rounded, so you want to stretch the pectorals by reaching behind. And the hams and calves are always tight, and that causes a problem in stair climbing, sit to stand, and in the gait pattern. So you want to stretch. See, it's easy with a band, or they can lunge forward. Mid back stretch. Most people have things in a small table in front. They're sitting on the sofa, so you want to stretch their mid back so that they can reach out in front. Overhead stretches to get things from the overhead cabinets and all that we have at home, even in the aircraft, although, reaching out for your luggage on top. Then side bending is for general overall, leaning across and reaching out for things. And the same thing for the trunk rotation, very important if you're driving or if you're crossing the road, or if you're just looking around in case someone has called you. And so all this. So again, you want to know whether the stretch should be active or assisted. Ideally, it should be active, ideally, because not only it builds up the strength of the antagonistic muscle, it's to support the flexibility, it also improves the balance and it prevents injury from happening. You don't want your older adult to have injury because of some stretching, and then them having that one of those barriers in their life saying, we went to the physiotherapist, lekin aur nahi jana hai because dard ho gaya tha. So final thing is balance. And so we've gone through strength, we've gone through flexibility, and then is balance. Again, this depends upon whether your sarcopenic older adult has a balance issue, but in case they do have a balance issue, you definitely want to work on it, because falls result in fractures, fractures cause morbidity, and basically a lot of immobility leads to mortality. So here we go. There are major problems. One of the contributing factors to balance is again poor strength and lack of flexibility. The other contributing factors are medication. Remember, a lot of older people are on a lot of medications. They take sedatives at bedtime. Then they need to go to the toilet very often at night. All these lead to various small issues. So your exercise prescription for your older adult needs to consider all of this, when you make it. So this is a balanced training protocol for fall prone older people, but I'm not getting into this. Generally, this is a research protocol that has been done, and I'll just take you through some videos where you would see the effects of balance training. It's very simple, which you can do at a patient's house or even, right? So, okay, so sorry, it says cannot play media, which is, sorry, I kind of got, okay, let's move on to the next one. That was just to show you how she was, there was an older lady that whom we trained, and so why am I not being able to do this? It's a large file and there are a lot of videos in this file. We'll just, okay. Okay, so Solder managed to get the video on. I'm sorry, the screen's got to become a bit smaller, but this was an older woman who had, who was obviously sarcopenic, and she had come with balance issues. So this is balance that we were working upon. This was her speed in the beginning when she came to us. She obviously was very skeptical about getting on the treadmill. Then, so we went about training her. So this was all the training that was done with her. It's actually very gratifying working with older people. You know, number one, they bless you, they get better, and you just feel so satisfied at the end of the day when you're working with them, making them better, making them, you know, they have such simple pleasures. They can do a little bit more activity. It's really very nice. And so this continues with the balance training, making her do tandem walk. Right. So we obviously individualize a prescription for balance, and there's a warm up again. We have set protocols, but then, as I said, we individualize it. I'm sure you will do too, and then looking at the strength, their flexibility, the muscle mass, everything, the functions that they have, the functions that they are restricted in, is what your entire prescription would be about. We would actually, again, for balance training, if someone just comes to us for balance training, then we still do a warm up of indoor cycling, because it's the simplest thing to do in a department. But in case they don't want to cycle, then this basic body motions or treadmill or whatever. And um, and then eventually we see things like this. So if you look at her in the beginning, which is one video which hardly played, and if you look at her post-intervention, as I said, it's very gratifying. Look at her speed, look at her go. See, my therapist who's standing behind her actually asked her, "Ki speed zyada to nahi lag raha hai?" And she says very confidently, "Na." So this is what it is all about. This is where you are reducing a person from this level to this level. What more can a physiotherapist want, when they see activities like this happening around them? This is why I guess we are in the profession. So, but then in balance training, you need to guard the patient because they may have a fall. You need to ensure because they've got low muscle mass and strength because of sarcopenia, you want to avoid fatigue. You don't want them to compensate. And your surfaces should be non-slip and things like that. If they need support, we need to give them support. We won't compromise on that. The other recommendation is our very own yoga. The elderly, of course, can do yoga. They must do yoga. And the same asanas are performed by the elderly as by the younger people, but the duration can be tweaked. The amount of flexibility that is required in the particular asana can be modified. And yoga has been modified. So, and also certain comorbidities like high blood pressure and all that need to be considered when you are prescribing yoga, or in case a person does yoga. You need to make them aware of that. So in a summary, as I summarize, what one does need to understand is that physical activity contributes to successful aging and prevention of sarcopenia. Although physical activity can confer a wide range of benefits, the majority of the people still remain inactive. Like unhe pata hai, but yet they tend to. So what we need to understand is that even small amounts of activity can be beneficial in sarcopenia. And even later on, it's not that, oh, now that I've become 70, ab kya shuru karna? No, even now, please start, please start. The basic thing is that when the patient comes to you, you need to change the mindset of the patient. So a lot of counseling is required of them, their family members, for them to understand the value of being, being active. So I kind of conclude now. So before I end, there's this Sanskrit slogan that I have. It says that mana eva manushyanam karanam bandha mokshayo, which actually means that man hi manav ke bandhan or moksha ka karan hai. If it comes from here. So if we stabilize this, if we can control this, then the body will follow. Namaste and thank you, Sancheti College of Physiotherapy, the Physio and Ortho TV department. Thank you very much.
Thank you so much, ma'am, for the wonderful session. Nilima, ma'am, I hand over the session to you.
Yes, and then if we can take few questions. There are one or two questions from me. It was so impressive. I've never heard so much in details about sarcopenia. Just yes, with aging, there's a muscle loss, and with aging, we see people walking very slow. But never thought that, for this, we could do something like this, which was very extraordinary thing, which I noticed, because we say geriatric clubs, these clubs, but we should measure this very specifically. Yes, even gradation of this. So when I got to know you're doing this, I just explored and I also read about it.
So, thank you, man. Thank you. That's good.
Yeah, it's very.
Ma'am, we would be happy to do a multi-center trial on this, ma'am, if you agree to it, because we have already done so much of research on sarcopenia but we are confined to Eastern India.
The numbers you have presented, and the number of people you have evaluated and marked them so much. And I feel we don't need expensive equipment to
No, not at all, ma'am, not at all.
That is right. Even if we can have a body composition analyzer and if we have a muscle mass on it or anything, what do you think about that?
Ma'am, we went to an old age home. We went to several old age homes. So, ma'am, we just did a calf muscle circumference because we found that is also a reliable and valid measure. We can't take a BI instrument everywhere with us. It's difficult.
But the simple measurements which you have chosen.
Yes, ma'am.
that is great, that it could be taken at a community level at so many places, isn't
yes,
it?
ma'am. Actually, at least we'll get the
To
basic.
identify this problem, I was not even knowing ICD has incorporated the code for it. So it is a recent development, I believe so, because when I had read that ICD had not even incorporated sarcopenia in it. So
there's a huge movement in the West, ma'am, because there
right.
they have a significant problem with the aging population. And
And we
as I
are
said,
doing the same now, eventually, isn't
yes,
it?
yes, yes.
I just had a thing in my mind whether type 1, type 2, anything also means not by simple measurement we can do, but do you know anything whether type 1 muscle mass like loss is more or type 2 muscle fiber loss is more? Any such thing is there? Or generally it's both, all the type of fibers of muscle get affected?
Ma'am, both
Like
get
normally we
affected.
say,
Yes, ma'am. I
yeah.
both get affected. I haven't read research where they've evaluated type 1 versus type 2. So far, I haven't read, but
No,
it's
I
a good.
haven't. But
No,
I thought,
I haven't
if
read.
you have
I
come
would
across
expect the
thing.
type 1 to go because as you grow older, like the slowness in the movements and everything, I would guess both would go, but type 1 would definitely go.
Right. And if
Course, I
a
mean,
person,
but then no, it's a very interesting thing. I haven't, so busy was I looking at the total muscle, this thing, that there must be physiology research on this as well.
and I would also like to know one more thing. When here we get people with polytrauma and they need so many surgeries and operations and they have prolonged immobilizations. So we do find that muscle atrophy is there. Our students take the girth measurements. But if that happens, then they will definitely have early or pre-sarcopenia. They will be like, 1 month, like it's a year, 2 years at times with the external fixators, can't do exercise much. So, do you think at a younger age also they come across? Have you come across the sarcopenia problem when they have multiple problems, musculoskeletal problems, and immobilization?
So far, the definition of sarcopenia has been traditionally confined to people above the age of 50 as a disease with
Yes,
aging and
yes,
a loss of muscle mass with aging. The muscle atrophy, which is like not so much as disease related as much as age related. But I guess what you're saying
okay,
is that muscle atrophy that we see generally, I guess it's
yes.
it's like we would be more prone to sarcopenia if we did not get that muscle back. I guess that would happen to a person who's
Yeah,
undergone
many times
polytrauma.
we find them after three years also coming back here follow up, and we still find that generally also they are still weak and generally debilitated because of so many problems. So I was wondering when I heard and got to know so much about sarcopenia from you, that whether any such thing is also there. And also disease like rheumatoid arthritis or people suffer from long-standing problem where inactivity is there. So they would have also sarcopenia or anything.
Yes. In so again, let's say a 30-year-old who's completely inactive
Yeah.
would therefore be sarcopenic because there would be loss of muscle mass.
Hmm.
But as I said, traditionally, like osteopenia, so far, like because the disease is well established, anybody even goes for a BMD DEXA and is classified as osteopenic or osteoporotic. Uh, because sarcopenia is still being explored, it's only been explored in the older people. But
Yes.
what you are saying is absolutely correct. If there's a younger person who's, let's say, completely inactive,
Hmm.
then would they be sarcopenic? Uh, Possibly, ma'am, no, because the age would protect them
Recover.
and the muscle would not shrink so much. But
Okay.
yes, if they continuously became inactive, then maybe one didn't have to wait till the age of 50 to become sarcopenic. Maybe they would become at 40, but maybe not at 30 because still the age is on their side.
So we should put them as health promotion activity.
Ma'am, bottom line is activity. It's like
So
basically is activity and exercises. That even recently, even in COVID, people found that the ones who are active and who exercise do better than the ones who don't.
yeah, so many angles it has. You have explored it, like, you have brought it to the community, because I've never heard about a talk on sarcopenia. We just get, yes, aging process, muscle mass loss, but to get the degrees of it and how we can overcome that. And it's so challenging to get exercises done for elderly, isn't it?
It is. It is.
So that
That is
outcome
very
which you have
challenging.
got, and now the walking and things, it's marvelous. And
Oh,
I'm
thank you,
really,
ma'am. Thank you.
yeah, we would really get connected with you for more information and the details and so many outcome measures you've
Yes, ma'am. I
explained
mean, like, I would
about.
love to share this with you, and I would love to have some research from Western India. I mean, your PG students could do it, and we would have data from all over India, which is what one wants.
Right.
And nobody better to do it than physiotherapists.
Yes, I feel so. That will be great opportunity. And thanks for sharing your knowledge and expertise. I know you are expert in many other things, but simple
Oh, ma'am.
TheraBand workout which you have shown is so good. Like upper extremity strengthening can be done so well with using the TheraBands, and the simple exercises you have shown for upper limbs. It's like very impressive. It's an extraordinary work you're doing there. Yes, it's great.
Please
Thank
read
you,
I
ma'am.
agree
questions.
with.
Sorry, please read questions in the chat and I'll answer it.
Yeah, I'll read out for you, ma'am. So one of our viewers have asked that, do you recommend any anti-aging supplements for prevention of sarcopenia?
No.
Farin, please read the doctor name also, like
Okay,
Dr. Prakash Keswani.
yes, it's asked by Dr. Prakash Keswani, ma'am.
No, not really. No, not really. We would just counsel them on uh, the nutrition part. They have found, so there's been obviously a lot of research on sarcopenia and things like that. So because people above the age of 50 or 60 for that matter have so many comorbidities, uh, it's uh,
Uh, Sorry, ma'am, we cannot hear you.
Parinman, there is one more question in the box. If you can that question also.
Right, ma'am. Another question asked by Dr. Prakash Keswani only was like, what is your take on carbohydrate intake?
Pareen ma'am, I guess Dr. Shabnam's video also has frozen. So can you
Right,
please
ma'am.
check whether she's connected with us?
Sure, ma'am.
Yeah.
So Nilima, ma'am, like till then, what is your take on?
I guess she has got disconnected. Yeah.
Just check whether she is there. Yeah. Can
No,
you?
Shabnam ma'am has got disconnected, ma'am.
Now she's got disconnected.
I guess we'll give her some time to join back.
Okay. Some asanas. Yeah, sure. Many actually. And we do use the body weight itself for asanas. So that is the beauty of doing asanas and having the muscle work in using multiple joints altogether. Yes, we will definitely think about giving a demo on asanas for this. And muscle bulk doesn't increase so much with asana as such, the girth, but definitely the strength and endurance increases. So we have a list of asanas for muscle strengthening and endurance, especially. But I feel we don't have time today, and we were not expecting to have a live demo. So we will have another session on the live demo, I believe. So what do you? Yeah, we'll just wait for Dr. Shabnam to join in. One more question. Okay. Okay.
Nilima, ma'am.
I'm so sorry. I don't know what happened. It just blanked out.
No, there are a few more questions, Shabnam, Dr.
Thank
Shabnam.
you. Yeah.
And how to manage a case of sarcopenia at level of PHC where there are no physiotherapists? That's a question. You can also see the chat box.
At the level of what? Sorry.
the primary healthcare center where a physiotherapist is not available.
Oh, so I mean, you know what? If the physiotherapist is not there, then the primary health provider just has to tell the person. See, remember, in sarcopenia, what do you need really? The simplest of things is asking the person to walk or do some activity and eat a protein-rich diet. Your research or evidence is telling us that milk-based protein is the best source. That's what evidence tells us. They've done a lot of other animal-based protein, although milk is also animal protein. But they find that this is the best. Why? Because it's a combination of calcium and there's a combination and protein, so that works best. So you don't need a physiotherapist. You just need someone. You need someone to tell them walk, and someone to tell them or do some activity, and someone to tell them that this is the diet that you should consider, especially women, because they tend to overlook these components in their lives and they are busy giving it to others. You don't need a physiotherapist. Physiotherapist is for urban people who
Right.
don't want to move at all.
There is one more question, ma'am. People on wheelchair, how to put them on activity?
People
Mr.
on
Sampik
wheelchair-
Raj has put that question.
So
Yeah.
are we looking at someone who's like on a wheelchair for a reason, or just age related? I mean, like just because they've got a knee problem or a
Right.
hip problem or whatever?
Yeah.
Um,
It's not been specified here.
Okay, so if
I don't know
let's
whether
say, for example,
we
that
are.
someone's elderly and they've got a problem with their lower limb joints and they are on a wheelchair because they can't walk. So, right. So now here there is a medical problem along with sarcopenia, which will develop. So in that case, you need a physiotherapist. In that case, obviously, you're not going to be asking the person to be active because they can't walk, but of course they can get onto a stationary cycle or things like that. But they can do upper body activities. So they can do those band activities that I showed in for the upper body, or they could just do with a water bottle. They don't need a band if they don't want to have a band. They could just do those, and then along with that, if once a physio has kind of made the person mobile, then they could work on the lower body. Okay, now I can get the questions. Actually, I didn't have any other questions here. Is aging a debilitating process? So is sarcopenia inevitable in old people? To an extent, yes. So I may get sarcopenia if it depends upon my activity levels. I'm replying to Dr. Satvik Raj. So if all of us will become sarcopenic, like all of us will have some amount of degeneration, all of us will age. Okay, but it all depends upon how we live our lives today and how much we do today. If you are good, so you have Amitabh Bachchan aging, and you have so many of the older people, I mean, of that age group aging. You have a Dharmendra who may not be on screen, but who's doing great things, farming and growing organic vegetables. And you have someone who's always on the bed, right? So everyone is aging as in age, but how we actually age is dependent upon our activity, how much you're engaged in mental and physical activities. That's why you will find that people who are always, in doing some work, they always are better than people who are not doing any work. Because then, and by work, I mean, let's say academic work, physical work, mental work, all kinds of work. So now Dr. Suraj Lekha, type 2 goes for atrophy in old age. Oh, is that a reply? If it is, it's fine. I mean, like, fine. I mean, like, I would find type 1, 2, because, those are the quick fibers. And if you do find that older people get slower in their reactions. So everything atrophies, everything gets affected. And that's the reason why which one goes faster than the other is something that, and especially if it's related to sarcopenia specifically, is a very fuzzy thing, because sarcopenia by itself, like, I haven't gone into so many details, but to actually classify a person as sarcopenic, it's still a bit we are still on muddy waters, because the prevalence and all that, when you have to really do research on it, you find it a bit wishy-washy. It's not as specific as osteopenia, that this is the standard, this is the mean, this is the standard deviation. Anyone below 2 standard deviations, or anyone below the Z score will be osteopenic. We don't have something like that for sarcopenia right now. So same thing, that both the type 1 and type 2 muscle fibers get affected. Your movement slows down and your endurance slows down. So the quicker your responses also slow down. So yes, both of them happen in old age. But yeah, if you've got research to tell us that it's only type 2, then fine. I mean, we can also share with us the research, this thing, and we can go further on this.
Yeah.
Okay.
Thank you so much, ma'am, for the best, I'll say one of the best question answer session ever.
Pleasure.
Yeah, thank you, ma'am. I would now like to propose our vote of thanks. I would like to extend our gratitude to the entire physiotherapy team for providing us such a wonderful platform. I would like to thank our ever-guiding light, Dr. K.H. Sancheti sir, our inspiring Executive Director of Sancheti Healthcare Academy, Manisha Sangvi ma'am, and Dr. Parag Sancheti, Chairman, Sancheti Institute of Orthopedics and Research. Also thanking our technology team and Mr. Rahul Chaube for all the support. And last but not the least, to our great viewers, without whom Physio TV would not be such a huge success. Thank you, all of you. Thank you, Shabnam ma'am. Thank you, Nilima ma'am. I, Dr. Farheen Patel, sign off for today's session. Thank you.
Thank you so much for having me. Thank you. It was lovely. Thank you.
It's our